I'm from a large family from Alaska, and knew from the time I was a little girl I wanted to be a nurse, and that was just something born in me, I guess. Once I got back home after graduation, they put me on the surgical floor, and one night the 3 to 11 gal in labor and delivery quit. And they had to wait for a gal to come from Canada, but she had to have her green card. So the nuns came and got me and said, Maria, you have to work labor and delivery. At least you know where things are. And I was like, huh? So there were 3 doctors in town that did deliveries. And they were all friends. And they called all 3 docs and said, when you have a patient that comes in, you have to come in with them. And you have to teach Maria what to do. How to do an exam, how to manage a labor, and these 3 guys did this. So I learned a lot from these guys and fell in love with labor and delivery. Many times you have people come and say to you, so what's the hospital rule? Can I? And we can say to them, well, you know what? There really is no hospital rule. It's what you want, what we want, what's safe for you and safe for the baby. And then we'll do it. So, what position can I deliver in? Do I have to be sitting? Do I have to be? No. I mean, I've delivered people under a table. I've delivered tons of people on hands and knees. It's where you end up. And where you think you're going to end up now may not be where you're going to end up at the time. Yeah, so we don't do any routine IVs. We don't do any routine enemas. We don't do any routine, baby has to have this, 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 and this. We try very, very hard to give everybody choices. Some of the choices we're not as excited about, but it's their choice.
Right.
It's not ours.
Yeah.
And you have to offer them all these tests. But I always say to people, there's options. When we look at these genetic screening tests, you could do every test possible, and if something's wrong, someone will say, well, I'm going to terminate a pregnancy. Okay, you decided that. Do every test possible. Second person says, I want to do every test possible, but I would never terminate a pregnancy. I just want to be prepared, and I'll get ready and join this foundation or whatever. And the third person says, I don't see any reason to do any of it. Whatever happens, happens. This is the way I want it. They're all okay.
Yeah.
And if you want to, believe and trust that your body isn't going to betray you, which rarely does that ever happen. It's like somebody going in and saying, oh, this baby's too big, we're going to have to do a C-section. If you can have a 9-pounder, that your body made a 9-pounder. If you couldn't, it wouldn't. So there's only one way to find out, and that's to labor and have that baby. My philosophy has always been to trust the process and the body's ability to do that, to instill that trust in the woman that she knows she can do it. Yeah. And once you do that, you're the overseer. You do not need to have your finger in there doing anything, but you can't be stupid and not know something might happen, but you don't bring it up front and count on it happening and make moves before there's any necessity for it. And I kind of think that's where we differ from physicians. I had a patient, we have a lot of people when they find out they're midwives that will transfer late in a pregnancy. And this gal was about 30 weeks. And so I was doing her intake and all this, and I said, okay, well, now we can listen to baby. And so I go to start to do the Leopold's, and she starts to cry. And I said, oh, I'm sorry. Did I hurt you? What happened? She said, that's the first time anyone's ever touched my baby. I guess with physicians, as I said, time is probably a little more important to them, I guess, when it comes to normal. If it's normal, then we can just keep moving on. And for us, we want to spend time reassuring and teaching. We do a lot of education on nutrition, on exercise, on lifestyle, a lot of questions on now, abuse and safety, mental health. We had a supervising physician, an MFM, in the very beginning, and he said to us one day, I don't know whether you girls get more people that have depression or on medications or have been on medications than any other practice, but I've never seen it so much in this as in your charts. And we said, well, Jim, that's because we ask and we're concerned because this is a real struggle, pregnancy and postpartum. And we want to be well prepared and we want them well prepared. And so we adopted the Edinburgh Scale for postpartum and utilized that a lot. We've referred a lot of people. I think we've been able to help more people. People are ashamed to say if they're having trouble, and we want them to get help.
Yeah, it's still a stigma.
It is a stigma, and I think that's missed a lot in a general physician practice. So even when people are asking for it, it's ignored. So we like to spend that time on that. So the doulas are so well, I don't want to say trained, but so well, they have that feeling for what's going on because they've done it enough, and they can tell by what we can, really. You don't need to be doing an exam all the time. You can see what's happening here. You can see fear, you can see trust, you can see progress, you can see stuck. And then you can start making suggestions for different things. And the doulas we've been using have been so good at this that we trust their ability to get patients through that time at home and be in more of a comfort zone. And so we really count on them. And then once we get to the hospital, we're all there. Now we've got another set of minds working and another set of hands that can rub, and we use a lot of essential oils and that type of thing. And so it's fantastic for us. I would like to see more midwives. I would like to see acceptance, particularly in this area. There's acceptance of midwives, but they're always thinking they should be in the outlying areas where we can't attract doctors. So they're like the second class, for delivering babies just because we can't afford to pay a physician a high fee for being in that area. I would love to see more collaboration. We have a wonderful thing going with the MFMs here. Feel very free in calling them. They call us. We consult all the time. We've developed a really good relationship, and that feels good. We've been very lucky to do that. But we just need more and more of that. We need more midwives. I would like to see more practices like ourselves, too, where you own it. Because what we see is if they're a midwife that practices in a hospital, they're owned by a big physician group or the hospital. If they do birth center, they can be owned by themselves, but they can't go to the hospital because they don't have a physician for the hospital. And then
you've got a very unique.
This is very unique, and I would love to see this become more of the standard too.
Oh, absolutely.
Where you are a private medical practice. You just happen to be midwives and you hire physicians. So we often think we should write a book. We've got a lot of really good stories. I think one of the ones I can remember is a gal that had it was either a clitoral or a labial ring that popped off. I thought it was going to be okay. We're not going to have to worry about it. Popped off as the baby was born, and it was 14 karat gold. And we had to find it. And so the nurse and I were down there, baby's up on the mother's abdomen, and we were down sorting through everything to find this ring so that we can get it right back in before anything closes. And we were successful. And the baby survived. Sometimes you just got to go to the...